Welcome to the Equine Vet Connect Podcast. I'm your host, Dan Carter. I'm a veterinarian and a farrier. The goal of this podcast is to educate horse people, break things down, bust myths, and keep it real. Speaking of breaking things down, here's my legal disclaimer to keep my attorney and insurance company happy. While I am a vet, I may not be your vet. Contact them before trying anything you hear on this podcast. Remember, just because you watched it on YouTube or heard it on a podcast does not mean you can do it. Please use common sense. All right, welcome back to the Equine Vet Connect Podcast here at Countryside Equine Hospital, a proud division of the Countryside Equine Hospital. I don't know where I was really going with that. I was trying to change up the lead in this morning, Dr. Brown. If y'all hadn't noticed, Dr. Brown's back with me.
Hello.
Shocker, she works here, so.
I'm here almost every day for something, so.
I don't know if we can, I shouldn't really, that's why I quit calling y'all hey, we got a special guest today, Dr. Brown, because she's kind of on the podcast a lot.
Doing my job.
Part of the podcast. So
one of the OG founders.
That's right, podcast. OG members. So, we're back here in the studio, Old Treatment Room 1. I don't know, if we ever actually get a studio.
We're going to have to design it so that it looks like the treatment room, or get a green screen.
Definitely.
I think
green screen
with the stalls in the background, I think.
I think so. And then change up. Maybe we have different backgrounds every day.
Mm-hmm. Now we're podcasting from Central Supply.
There we go.
Mm-hmm. From the barn.
Today's broadcast. Now we're in the laundry room.
Yeah, why not?
In our lab.
Mm-hmm.
Yeah.
Possibilities are endless.
It truly are. Truly are. Well, speaking of endless possibilities...
What a segue.
That's what happens when you're a professional podcaster. Mm-hmm. You learn how to segue where you need to go. Mm-hmm. So today we're going to dive into diarrhea part 2.
Part 2.
So this is a very interesting topic. We're going to be talking about inflammatory bowel disease, IBD. This is a condition that I think sees us more than we see it.
Yes.
Meaning that I think it goes underdiagnosed.
Yes, and it's kind of it's not a new disease, but I think in the last 20 years, we've been able to actually start characterizing different IBDs.
I would agree.
It's not just, one thing. I think from what I could see for a while, IBD was just the diagnosis of, we can't figure out what is causing this diarrhea, so we're just going to put it under IBD. But Now IBD has kind of become more of an umbrella term for a lot of other diseases, and they sound similar, but when you start kind of looking into the nitty-gritty of it all, they're actually very different. And some of that I think is going to go into, how we treat them and what they look like, and and maybe even from there we'll learn even more, and we can actually do some very specific targeted therapy with these.
I think that'd be pretty awesome because, to start out, let's talk about what is IBD. Obviously, from the lead-in, we know one of the clinical signs is diarrhea.
Diarrhea, yes.
But one of the things I often say is that they don't always have diarrhea.
No, they don't.
It can be intermittent diarrhea, it can be seasonal diarrhea, or it can be diarrhea all the time.
Mm-hmm. In general, it's inflammation of the bowel.
Mm-hmm.
That's a really crappy way to describe it, but
I don't know where they came up with the name.
Crazy.
Yeah.
But it's some sort of inflammation of the bowel that causes maldigestion, which is the inability of the gut to absorb nutrients, and that can lead to a protein-losing enteropathy.
So protein-losing enteropathy, protein's just moving straight through. We're not maintaining any of that. So, and like I said, in a lot of cases, it can cause diarrhea, colic-like symptoms. Mm-hmm. That's chronic recurrent bouts of colic. This one kind of moves onto our list.
Yes, especially these very kind of non-specific colics, where you can't identify specific cause, put the round bale out, and they're going to colic when you put the round bale out, or it's been really hot and dry, and we're not drinking any water.
This giant, massive impaction somewhere.
Right. Where it's these little colics, and they can be mild, but they could be, pretty severe, that they're super painful. And, we go through the whole treatment. We're like, we don't know what's wrong. Mm-hmm. We can't find anything. So.
And like you said, when we start talking IBD, that is a really broad, generalized term. It kind of encompasses a lot of different conditions that we're going to talk about. Mm-hmm. And I think it's very similar to people, because if you really look at the work in IBD in people, it has really, and I think that's why we've advanced in veterinary medicine.
Yes.
Is because they have advanced as well.
Correct.
Because usually you had IBD. That sucks. Mm-hmm. Now they're like, I don't know, we got different kinds. We're getting further.
And there's different medications now that target these very specific pathways that come into things. And so, maybe one day we can get that in horses.
I'm hoping so. So when this pops up on the list, and when y'all hear us talk about the list, in Vet Med, we have like a rule out list. So we start listing everything we think it can be, and we start going through those things. So we're always building a list. They're not type A or anything. So it ends up on the list. Now we got to start working through a diagnosis here. Oftentimes blood work can be helpful.
Sometimes.
And just because the blood work doesn't agree with IBD does not mean it's not IBD.
I'd say the one thing that tends to be the most consistent across the board with these guys is hypoproteinemia, or low protein circulating in the blood. Because as we talked about earlier, our protein is not being absorbed in the gut, it's being shot out the butt.
So a lot of times that hypoproteinemia is the result of that protein losing enteropathy where it's passing through the horse.
Correct.
And particularly albumin.
Yes.
That's the part of the blood protein we're looking at. It's typically that albumin that's low. Lymphocytes, interestingly, I've seen them extremely high. We've got some blood work on the Wall of Fame. What was it, like 76,000 lymphocytes?
Insane, yeah, like absolutely crazy. That I think they ran the blood work twice because they were like, that's not right. Something's not right. And
even
then
the outside lab was like, that can't be right. And they're like, nope, that's right.
Look at it under a slide, and it's just white blood cells everywhere.
Lymphocytes.
Crazy.
Yes. So that can sometimes happen. I've seen it where they're low, where it's like we don't have a lymphocyte.
Right.
Well, that's because they've all, as you'll learn later, have all headed to the
They're all
tract.
in the gut, yeah.
Yep. So the other thing is ultrasound can be really helpful in these cases. Looking for that thickened, typically it's small intestine, looking for that thickened small intestine.
And this wall gets thick.
Yes.
Thick. So most of the time when we're doing an ultrasound on a horse and we're looking at the abdomen, a lot of times we can't even see small intestine unless it's abnormally large. And so just being able to see small intestine is already kind of a red flag. We're like, what's going on here? But this wall can get extremely thick, almost sometime to a point that, and one of the diseases we're going to talk about, that wall is so thick it almost causes an obstruction within the gut itself.
Right.
And that in turn can cause some colic signs. And so, where you have some of these horses where they have this section of bowel that's just so chronically inflamed, you've almost now just created an obstruction in your gut that we can't get rid of. And so one of the things that we do for this in particular is we cut out that section of bowel.
Right. Absolutely. So that's definitely something we look at, see ultrasound, and also the amount of fluid that is in the peritoneum.
Yes.
Because now this is usually more of that end stage. You'll have a massive amount of, we call it ascites or peritoneal fluid. They'll have almost like a pendulous abdomen, but that's more towards the end stage on these.
Right.
Then we start to get into, when we get into histopath. So this is where biopsies are taken. This one's a lot less commonly used because I think every veterinarian out there has a hard time saying or justifying, let's go basically do a colic surgery and biopsy small intestine.
Right.
Like that'd be a great thing to get an answer, but there's a lot of risk to go with the colic surgery. So it's not, I'm hoping maybe through laparoscopy, this might become more common and easier to do.
I think that's what they do in people.
They do it in people.
They do that in people. So unfortunately, with the way that we are really limited to doing biopsies and, kind of our generalized practice is if you have a gastroscope, being able to go into the stomach and either taking samples of the stomach, or sometimes you can get into that duodenum,
right,
where you can get some samples, or we can do rectal biopsies where we get tissue from the rectal mucosa. But, we know, as we talked about several times on this podcast, horses have 120 something feet of intestine on average. And so we're only really able to access maybe a couple feet of that, if that.
Right. And you've got to find the right spot.
Right.
And so if you biopsy the incorrect spot, you may get a false negative. So if you get a positive, you know it's positive. But if you get a negative, maybe we didn't get the right spot.
Right.
So,
and it's very much looking for a needle in a haystack.
and that's the gold standard. If you can find it on the biopsy, that is the gold standard. This is what you've got. Just unfortunately, logistically, that's a more difficult test to do.
Right. So a lot of times where you end up getting these is either they've gone to colic surgery because we're looking for something to explain, these kind of unspecific colic signs, or we're doing this on a necropsy.
Right.
So unfortunately, that's where a lot of this comes from. But again, like we're talking about, laparoscopic is kind of an up-and-coming thing in equine medicine specifically. And fortunately, equine med is several decades behind human med in certain things, but
some ways we're ahead, some ways we're behind.
Right.
And when we're behind, it's just because it's just the sheer size and logistics of doing this procedure.
Right.
I mean, when you look at an equine laparoscope, this thing's in, the camera itself could be 2 to 3 feet. I mean, these things are massive.
Right.
So, some of us waiting on the technology to catch up to where we can do this. So, which leads me to my favorite test. I use this test a lot. It's kind of an old school test.
We do this test a lot.
But it is a very valuable test, and that's an oral glucose absorption test.
Yes. It's a fun one, and it's super easy to do, honestly.
Very easy and a lot of information there.
Yes. So basically what this is we will fast the horse overnight, and then we will give them caro syrup, usually through a nasogastric tube, so that we ensure that it hits their stomach. And then from there, we take serial measures of their blood glucose levels. And we watch how that blood glucose changes over a period of time. We usually were running this test anywhere from about 3 to 4 hours, sometimes even more, kind of depending on what we're seeing as we're doing the trends. But this really gives you a good idea of how well is their gut absorbing nutrients.
Right.
Because caro syrup is just straight sugar.
Straight sugar.
So this is probably the easiest thing that the body can absorb. So if the body is having trouble absorbing very simple sugars, we know that we've got something going on.
Correct.
That our gut is not working.
Because, there's both active glucose transporters, but then there's also passive.
Right.
And so this should be very easy to absorb.
Yes.
And so if it's not working, we got a problem.
Right.
And this is the test we use quite a bit, and it's kind of we're always looking for that slam dunk test, that slam dunk thing. But what I like to tell everyone is we're going to have several tests in here, and then we're going to look at it and formulate a diagnosis. Now, this one, if it hits, if we're less than 85% absorption,
we've got something going on.
We have something going on.
And most of the time, I'd say when we are bringing these horses in here, they're showing some sort of partial malabsorption because we've already worked up these cases. We've done fecal samples to look for worms or, bacteria or pathogens. We've, been trying some different medications. Maybe we've tried antibiotics. Maybe we've tried steroids. Maybe we've, done a gastroscope already too and looked for ulcers or what have you.
We've
So
looked at diets. We've got nutritionists involved.
Yeah,
everything's lining up. This horse should not be losing weight, but now it is.
Yes. And these weight losses too on these guys can be very fast.
It can, yes.
Very fast. We've had some people that they show us a picture of the horse from 6 months ago, and then they show us, and then we're looking at them now. We're like, that is not the same horse.
Well, and you go through with them, they're like, I'm feeding them everything I can. That's one of the big things that starts to tip me in here is if they have diarrhea, chronic diarrhea, but they're not sick, that's an indication of IBD. Or if they're literally feeding these horses everything they can and they're losing weight in spite of it, and you do a nutrition consult, everything's doing great from a nutrition perspective, but then they're still, 30 days in, we're still losing. It's like, okay, because if you think about it, you got nutrient in, that's one way we get energy, but if that nutrient's not absorbed, it doesn't do the horse any good.
Right.
And that's what happens here is you just get poor nutrient absorption.
And it's a frustrating thing too, because you'll see these owners, and a lot of times they've got multiple horses, and they got some fat horses on beautiful pastures with the best quality hay grain you've seen, and then there's just this one horse that's they're eating everything. And
that's one of my indicators. If I show up and I got 5 horses that look great and I got one that doesn't,
something's going on. Something's going on. And
so let's jump in. There's different kinds of IBD. That's what we're learning over the years.
Yes.
We're breaking this out in these categories. Let's talk about the first one, granulomatous enteritis, old GE.
Old GE. So this one is probably the most similar to Crohn's disease in people, or Johne's disease if you're familiar with cows. So this one's kind of an interesting one because they think that there's almost like some sort of hypersensitivity reaction to something going on here, like some sort of immune mediated response to, something in the diet, maybe even parasites or a bacteria. But what we're seeing with these guys is this like massive infiltration of lymphocytes and macrophages.
Yes.
So when we're looking on that biopsy, that's kind of your big, key indicator that you got the GE going on.
Right, and that's one of the things we'll do is often get an abdominal fluid sample, and if you see that's really high in lymphocytes and macrophages, because this is where those cells are migrating into the intestine, well, some of those leak out into the peritoneum. If you see that really high count in lymphocytes or macrophages in the abdominocentesis, or the belly tap, as we often call it, that can be an indicator you may be dealing with this one as well. But when those things flood in, it causes that acute swelling.
Yes.
Of the intestine. And what I guess where we should have kind of talked about this a little bit is the intestine's a tube, but inside that intestine there's these structures called microvilli. So imagine a ton of these little bitty folds. Okay, so the intestine is not just smooth on the inside. When you look at it microscopically, there's millions of these folds, and what that does is increase the surface area for absorption. And what happens with a lot of these IBD cases is when you get more of that fluid inside the lining of that small intestine and it gets bigger, it flattens those folds out, so we're losing surface area for absorption. But then you also get what they call villi blunting. And that's where these microvilli get shorter and smaller. And again, losing that surface area for absorption. And so it's one of the consequences of IBD, especially with the GE one. So,
yes, and this is one too with a lot of these diseases. They tend to profile them in younger horses more than anything. I'd say in my experience, I kind of see a mixture of both of these. Like I see younger horses, and by younger I mean we're talking less than 5 years old. But I feel like I see this in a lot of teenagers and 20-year-old horses. And again, I think that kind of goes back to what we were saying at the beginning, that this seems to see us a lot more than we see it.
That's the interesting thing. We'll see it in these teenage to older horses. But when we start going back to the history, if the owners had the horse since it was young, this horse has always struggled to thrive. Like it would survive and it would look okay, but it never would bloom.
Correct.
Like the other horses. Like it just wasn't, this coat wasn't as shiny. They didn't carry as much condition. They just never seemed to do as well as the other horses in the herd. So
I've even seen some horses too that they're like, they've had loose stool their whole life.
Right.
And, they always just kind of define them as, they're just a hard keeper. But I'm like, is this some sort of low-grade IBD that we're just living with?
Well, and often the history is like, it gets this every winter.
Yeah.
And they assume it's just from switching over to the hay.
Right.
Which sometimes the hay or different forages can be the root cause of this GE, this gastroenteritis.
This is kind of where we talk about food allergies and food sensitivities. This is kind of where that comes into play. Again, it's food allergies and all that. That is like such a hot topic and everything and all that. So we're not going to dive into that too much today because we're going to ruffle some feathers, I think, if we get into that. But this is one of those things that it's like, yes, this is kind of scientifically where that would come into play. And where we could theoretically say, hey, let's do some food trials. Let's see what are our trigger foods. Maybe if we cut out this certain type of hay, or this kind of ingredient in something, is that going to maybe resolve some of these signs?
And I think I always say that's step 2. Step 1 is getting the IBD diagnosed.
Right.
Step 2 will be looking at some of these feeds that may be causing this allergic type reaction.
Correct. So
This hypersensitivity.
yes.
So let's jump into the next one. We don't see this one often, but when we do, it is, for a veterinarian, it's quite satisfying because it will explain so many things when you get this diagnosis. And this one's called MEAD, multisystemic eosinophilic epitheliotrophic disease. It's probably the last time we're going to say that in the podcast. From here on, we'll be calling this MEAD.
MEAD.
This is one of the more devastating forms of IBD.
Yes. So this one, because it doesn't just affect the GI tract, it takes over everything.
That would be the multisystemic part.
Yes. It's in the liver, it's in the pancreas, it's in the skin.
Yes.
Which is really where a lot of times that's where we kind of get our big issues that come up, is we see these horses that just have these like extremely awful dermatitis. Their skin is red. A lot of times the hair in the skin itself is just sloughing off. It almost looks like they have like a really bad sunburn. And they'll get it on their legs, they'll get it on their face. They can start getting it across their whole body as this disease kind of starts to progress. Their mucous membranes, which are, their gums, they'll get really ulcerative and red, and they're painful, and they'll get them on their coronary bands as well, which is, again, super painful. But these horses look a mess. But a lot of times by the time we're seeing some of these really severe outside lesions, we've already got a lot of issues going on in the body.
Right. Usually the skin is oftentimes the secondary reason we get called.
Yes.
But you'll see these skin lesions with diarrhea, skin lesions with weight loss. It starts to raise your thought process, like, is this what we're looking for? And you've got to be careful with these too, because every time you see a diarrhea case, you don't want to be thinking, oh, I've got IBD. There's a lot of other causes. This is just one particular road we'll go down.
And again, this is a rare diagnosis
Very
too.
rare.
This is extremely rare. Like, this is, I think, on a lot of our bingo cards.
Right. And it's, I've had, in 15 years, I've had 3.
You've had 3 confirmed.
3 confirmed
3
in 15
confirmed.
years. So it's not the most common of all the conditions.
No.
But we don't need to forget that it's out there. And like I said, it is multisystemic. So where I start getting clued into this one's when I have these chronic non-healing wounds, when I have these wounds that just seem to show up with no overt cause. Couple that in with some weight loss or ill thrift. Maybe they have diarrhea, maybe they don't. But they're just kind of ill thrift, not doing well. This one's on my list. And it's, like I said, it is one of the more devastating ones.
Yes.
Because I have not been able to manage one of these, because I want to be honest, folks. We don't treat any of this. It's no different than IBD in people. We're going to manage this.
Right.
Long-term management is usually quite unsuccessful.
Right. I have, what I've been describing IBD to clients and some of my family members, or their animals have had it. I'm like, with IBD, it's like you have some that are really bad, and then you have some that are a little bit bad.
Right.
It's just kind of, can you manage this, and for how long can you manage it? Because it's all, as we kind of get into when we start talking about treatment, a lot of times we can, make some dietary management with things. We can do some medications. We can, kind of keep them a little comfortable and slow the progression of these things down. But most of these are not curative.
Right.
At all.
Right. And one of the big things I look for with MEAD that makes me start considering not just the clinical signs. I think your clinical signs are a big part of that diagnosis. Blood work will often see in the eosinophils kind of just sit there, and like we all scan through it on a CBC differential, and we just kind of look through there. There's very seldom anything different with the eosinophils. But if you see an eosinophilia where you have a lot of eosinophils in the blood, or you see very few eosinophils. You actually see low eosinophils. And when we see cells that are low, our question is, where are they going?
Where are they? Yes.
Like, they're there. Where are they?
They're not in the blood, so they're somewhere else in the body.
Where did they go?
Yes.
And that's really any time we see like low white counts, whether it be a neutrophil, a lymphocyte, macrophage, eosinophil. When those things are low, the very next question we have as vets is, okay, where are you hiding?
Right.
Where did you go? You're not here, so you're hiding somewhere.
Right.
And so when I'm seeing a lot of these clinical signs and I see those eosinophils either really high or really low, this one really starts to creep up.
Yeah.
We're going to start down the road of getting this workup done. We're going to start with that abdominal ultrasound. We're going to be doing that glucose absorption test. We're going down this road.
Right. And I think, again, too, the thing to point out is blood work is just a picture in time. It is just one moment. And so a lot of times when we are doing blood work, even if we get everything back and everything is in the normal range, that doesn't necessarily mean that everything's normal. It just means that we're not seeing anything. So right, exactly. So a lot of times when we are working these horses up, we'll say, okay, I want to recheck this blood work in 30 days because maybe right now the white blood cell count is normal, but in 30 days, I might look at it again and now our white count is very low because all of these white cells have migrated.
Yeah, they have they have marginated, they're gone.
Yes.
And that's the other thing is when I talk about that eosinophilia where I have a lot of them or that low eosinophil count, those are the great ones because that's more that slam dunk, heck yeah, let's run down this road. More often than not, though, the eosinophils are normal.
Right.
Why? Because this has been going on for a while, and the body's like, hey, these eosinophils keep leaving the blood. I should increase my production.
Right. That's why I'm like, sometimes when I get blood work results back and I see, a bunch of red on there or things are abnormal, I'm like, great. I actually have something to explain what I'm looking at. But then when I get my blood work back and everything's in the normal range, I'm like, well, crap. I got to run blood work again in 30 days because.
And one of the things we look at is like what stage are the clinical signs. Sometimes we maybe look at them like, well, it's been getting better. Okay, well, I need to get out here when it's like a really bad day. When it's bad,
yes.
When it's a really bad day, when this first starts up, I need you to call me and let me get out there right when this is going because we may be able to get more information. So that's a very important fact.
Yes.
All right, another one, idiopathic focal eosinophilic enteritis.
IFE. I think I don't know if that's what they call it, but.
Yeah, we're going to call it IFE.
IFE. Yeah. So this one's a little similar to mead, but it's got a very kind of different presentation and all that. But so again, with mead, we're looking at eosinophils going into the intestinal wall and causing all of our signs. In this one, the eosinophils are going in there, but they're not diffuse like in our mead cases. They're hyperfixating on one spot in the gut in particular. They can go in the large intestine, they can go in the small intestine. Particularly in the large intestine, they see it in the left dorsal colon for some reason. I don't know why, but that's just where it likes to go. But basically what happens is they'll get this, inflammatory response, and all these eosinophils and some macrophages will go into these intestinal walls, and it creates this band of just thick tissue. And this is what we were talking about earlier, where we get these obstructive colics that now nothing can pass through. And so these horses will, rather than presenting with more of a diarrhea or, kind of that chronic ill thrift, we see these colic signs that just can't really be explained by anything. And what's frustrating about this is, again, a lot of times it's focused on one section of the small intestine. I mean, and this section can be, a couple inches long, or it could be a couple feet long, and you have no idea. And so you could be, rectally palpating these guys. If you get lucky and it happens to be in, the 25% of the abdomen that you can feel, you might be able to feel that thickened intestine there. If you're scanning the abdomen on an ultrasound, you might be able to see it, but you might not.
Well, that's the hard part because you've got roughly 76 feet of small intestine in the in a horse. I mean, that's kind of average. Bigger horses, there's longer. Well, the problem we run into is we have colon on one side, and then we've got colon and cecum on the other side. Small intestine all lives in the middle. So we have very small windows where we can access and image the small intestine.
Correct.
Like I would, if we can see 10% of the small intestine on ultrasound, I would say that might be being overconfident on how much we
Exactly.
see. Like it's probably closer to maybe 5%.
Maybe.
And so we do these ultrasounds, and if it shows up in that 5%, fantastic. If it shows up and we see that thickening in that left dorsal colon, fantastic. If it doesn't, all right,
then we don't have an answer. Again, we're back in that, well, this is what we might think it is, but we don't know.
And this one, it can be quite transient as well.
Yes.
And so even if you go in and you do a surgery, you open them up and say, how I'm going to run the entire intestine and look at it. One, we still can't see all the small intestine.
Right.
Two, we got to hope that lesion is present and we can visually see it at the time of surgery.
Right.
So again, I think that's what limits us more than humans, because humans, they can put you in a CT, right?
Oh, yeah.
I mean, you get to go in a CT and they can see everything.
And then you have an answer in 15 minutes.
Yes.
Right. We don't have that for horses at the moment.
At the moment.
At the moment. You never know.
They don't really fit. So, yeah, we're a little more limited. Mm-hmm. And so I think when I tell people, if we're going through this, you're going to have to be patient, because this takes a bit to get diagnosed.
Right.
And when we get into treatment, you'll understand why we really want to get this diagnosed before we start going down the treatment route. Because the treatment, it's not unsafe, but at the same time, it has some risk.
Right.
Like it has some side effects.
Right. I mean, anytime we're talking about doing abdominal surgery on a horse, we are already, making a list of pros and cons.
Right.
And that's even in a healthy horse.
Correct.
We have a list of pros and cons. And, the issue with this is we have horses that are not necessarily healthy. They're having diarrhea, or they're very ill thrifty. Again, where we talk about we don't have protein in our blood, that's going to make it very difficult to keep these horses, blood pressure up during surgery and support them. And then recovering afterwards is a lot of work.
Yes.
And again, that's in a healthy horse that we haven't even really done anything.
Right.
And if we start taking large sections of intestine out of these horses, that's a lot.
Yes.
That is a lot.
Yeah. So kind of the next one on our list is the lymphocytic plasmacytic enteritis. I like to think this one's very similar to the HGE, just our cells are changing.
Yes.
So it's what cells are present on that biopsy.
Right. And this is, lymphocytic plasmacytic. It's in the name. It's lymphocytes and plasma cells. And this one's interesting too, because they almost think that this is a precursor to lymphoma.
Right.
Because the changes that you see here are very similar to what lymphoma actually looks like, which lymphoma is cancer of the lymph cells, so the lymphocytes. This typically affects younger horses as well. It's been mostly described in the literature in 2 to 4 year olds. Again, it's not necessarily limited to that. We think maybe we've had some older horses that can get this, but the kind of poster child for this is just these young horses that are just extremely ill thrifty. They're not gaining weight. They've got diarrhea. They look poor, and we've wormed them 100 times and nothing's worked. We've thrown them on every antibiotic, and they're on all the feed in the world and nothing is working.
Right.
Yes.
That's when we start going to look here.
Yep.
And going back to the lymphoma, a lot of the work, when you start looking at these lymphocytes, they do have a lot of those same markers that we see with lymphoma. And I think more and more, I know I'm guilty of it, I group it into lymphoma.
Yeah.
And you've got a lot of people that are starting to group it into that lymphoma category.
Right. But they are, they're different diseases,
Yes.
technically, because they look similar on a histopathology. So this is all kind of speculative. But again, our sample size is pretty small.
That's really the issue we run into is we
yes.
got small sample size here.
Because, again, with a lot of these horses that, we're seeing out in the field that have these signs and we're saying, okay, we think this is it. A lot of times we're not able to, do biopsies.
Right.
And so, we're kind of making these guesstimates as to what we think it is. And then, sometimes owners will opt for a necropsy, but with a lot of them, that's not an option. They don't want to do that. We're able to do, in-field necropsies on these horses and get our own samples. But again, some owners are like, you know what, it's fine. And it's kind of more of something maybe for us and maybe to get some closure on something. But with most of these, again, we're not actually figuring out what the true cause is.
Right.
So.
Correct. Like that's where I think ultrasound and that glucose absorption test, those are my two big go-tos. And it may take multiple of those to get this diagnosed.
Yes.
Depending on where we are in the condition, how early we are in the condition. We may have to do a couple of those tests to really get this. It may be normal on one, but then if we were to retest that horse or re-ultrasound that horse in a month, it may give us the answer.
Right.
So unfortunately, just because you passed once doesn't mean you're going to pass again.
Right. Or we may do it as kind of a progress test and we say, hey, how are we responding to our treatment? So we can segue into treatment on these, which is kind of a shorter segment.
Yes, it's a very short segment because unfortunately we don't have enough. We don't have a lot because if you think about it, most of these are caused by a hyperactive immune system. So most of our treatments are going to focus on immunosuppression.
Right. And our best way to do that in horses at the moment is high doses of corticosteroids.
Yes. So when we talk about why we want to have this diagnosis and not just start treatment right away, high doses of corticosteroids do have side effects. They do have issues.
Yes.
But if you are dealing with an IBD, the reward way outweighs the risk.
Yes.
But if you don't have again, it goes back to what we said 100 times. Surgery's trauma, medicine poison, alternatives witchcraft, absent a diagnosis.
Yes.
Once you've got it, now the reward way outweighs the risk.
Mm-hmm. So. And one of the issues that kind of comes into this is a lot of our, I think pred is probably our safest corticosteroid that we have, prednisolone.
Let's go with safest. Remember the ST. It's not safe.
Yes, we kind of have two options when it comes to corticosteroids. We've got prednisolone and dexamethasone.
And remember the L?
Prednisolone.
That's the activated form of prednisone. 50% of horses cannot convert prednisone to prednisolone.
Yes.
We don't know which 50 those are. So we got to have the L.
Yes. And prednisolone, unfortunately, the only way that we can really administer it to horses is orally.
Right.
But in the case of IBD, our gut is not absorbing anything.
Correct.
So you see the issue here.
That's why a lot of these we end up on some type of an injectable dexamethasone.
Right.
I've actually even done immunosuppressive doses of triamcinolone.
Oh, really?
If I'm in a situation where IV dexamethasone is not an option, I've actually used immunosuppressive doses of triamcinolone.
Wow.
Is it my favorite? Absolutely not.
Hold your breath a little bit.
Yes, because if I had one of the big side effects with steroids is laminitis.
Yes.
And if I had to say the one, and this varies based on region and based on individual experience, but in my experience, triamcinolone is the one that makes me worry the most about laminitis. Dexamethasone's number 2. Prednisolone, kind of the running joke, if they found her on pred, it's coincidence. But it could still happen.
Yes.
So prednisolone's our goal.
Yes.
But like you said, if they're not absorbing, then oral medications aren't going to get us where we need to be.
And so sometimes, especially for this kind of initial high dose therapy that we're getting in, we're going to need to be aggressive with, our injectable steroids. And, the nice thing with dexamethasone is you can give it in the vein,
right.
You can give it in the muscle. And they both have, The muscle actually has some pretty decent absorption,
I like to call it an IH drug. It just needs to get in the horse.
Intra-horse, yes.
IV, IM, orally. Just get it in the horse.
You get it in. It's a fairly affordable drug too. So, but it's if they have to absolutely live on this full time in order for them to be able to thrive, then, again, outweighing our risk and our reward and seeing that. But, sometimes we can get them to a little bit more of a controlled state and we can transition them to a prednisolone, which, in my experience, we can kind of keep them on long-term prednisolone and they can, still be okay, especially if we can get them to a lower dose. Sometimes these horses, we can get them to just kind of a periodic dosing. Whenever they're having signs, we can, hit them with a high loading dose and then kind of taper them down and get them off the steroids. There's some horses that they need to live on these steroids for the rest of their life.
Yeah, I've had, like you're saying, I have some that we can pulse it to a few times a year. Some we get down to an every other day dosing. And I've had some that, immunosuppressive on a horse is somewhere around 1,000 milligrams of pred. We taper those horses down. I have some that live at like 200 milligrams.
Yeah.
And that's the thing is we're tapering these steroids. We're monitoring how the horses are doing.
Right.
And what we like to say is we want to find the lowest effective dose. And so that's part of that taper is monitoring those clinical signs to see where is that lowest effective dose.
Yes. And, that's is where keeping a journal is a really good idea. So, what dose are we on? What's our feed situation? Did we change feeds recently? Did we drop our dose? Was there a weird change in the weather pattern or something? If, environmental stresses are kind of a portion of this as well. So keeping a journal and knowing where our horse is going to be very helpful for this. And again, sometimes we need to fiddle with it. Sometimes we're doing okay at maybe a 200 milligram dose. Sometimes we need to pop back up for a couple days just to kind of get things under control. But this is something that it's going to be very dynamic, and it's going to most likely be a chronic thing. This is not going to be something that we throw some medications at for a little bit and it goes away and we never have to worry about it again. This is, I'd say 99% of the time, this is something that we are going to be dealing with long term for the rest of this horse's life, most likely. So
it's definitely a management issue, not a curative.
Correct.
And that's the thing is like once we get these under control, we briefly touched on it. This is where we can start to play a little bit with different feedstuffs. I've had the literature says like soft forages are better for IBD, but I've had some horses that was not the case.
Right.
And so you can start, but until you get it under control, there's no point playing with the diet. I like to get things under control, keep a journal, start to figure out what's going on, and then we'll start playing with that diet. Like I like to tell people, like we're marathoning here.
Yes.
Like once we get it diagnosed, that's great. But figuring life out for this horse, this is not going to be a one visit and we're done.
Right.
We're going to be highly involved. It's going to take a little bit.
Yes. And so with these guys, they've found that, a lot of small, frequent meals throughout the day can help these guys. Right. So rather than just, throwing them a big pile of grain in the morning, we can make them little meals throughout the day, making sure they've got lots of good quality hay, forage, and very high energy feeds.
Right.
Again, these horses are having difficulty absorbing even the simplest sugars.
Correct.
So we don't want to be throwing them, tons of protein, tons of fat, everything. We want just carbohydrates. It's going to be our kind of best thing. Carbohydrates are the probably easiest thing that our body can break down, and that's what we want.
Yep. So that's where we really want to pay attention. Like, don't buy the old crunchy hay. We're going to start with that softer, easier to absorb hay. Now, I've had some that, for whatever reason, they didn't like that. Those are very, very few and far between.
Yes.
Very few and far between.
Yes.
So, one of the other medications, and I've tried this one, the azathioprine. I've not had success with that one. It's another immunosuppressant medication, but I've just not been.
They use this in dogs a lot.
Yep.
I know with IBD. and I know it's had some success with things. I think it really kind of depends again on, what type of IBD that they have, what are our signs, what other management things are we doing. We just don't really have a good way to give it to horses right now.
No, not really.
No, and I don't even think it really absorbs super well in horses anyway.
It doesn't. Even on the in vitro studies, it hasn't been that great at controlling the lymphocytes.
No.
So it's not been a great
Right.
medication.
But again, I mean, that's kind of we have very limited options at this point for these guys. And, I generally tell people, if we're working with an IBD diagnosis or a suspect IBD diagnosis, our prognosis is generally poor for the majority of these. This is most likely going to be, the thing that kills them. But sometimes it's manageable
Right.
with steroids and some dietary changes and just being very vigilant and looking at things. But sometimes it's not.
And I do feel like it's one of the sooner we can catch it, the better chance we have
Right.
at prolonging this. Because I've had some that can live a fairly normal life. Now, is it's going to be as long of a life? Not really.
Probably not.
But if we can catch it sooner, we can definitely have a lot more options.
Right.
Another medication that we used to use, I don't even know if they teach this anymore, is cleoquinol. So it's an anti-protozoal medication, but for whatever reason, it has some type of immunosuppressive effects on the GI tract. The hardest part about it, and it's got another name, it's like odhexol, blah, blah, blah. I can't.
Oh, okay.
It's that really long one. Cleoquinol is what we're going to go with here, because I can say that. But I've actually used it quite successfully and I like to say it does not take the place of a steroid, but it is steroid sparing. So a lot of times I can get the dosage of steroid down on these horses using cleoquinol. Your biggest question there is availability.
Right.
Because I had several horses we were managing really, really well on it, and then we couldn't get it. And I know last year I had a horse on it, so it was back, but then again, it disappeared. And so there's and I think a lot of it has to do with we may be the last people on earth using it. And unfortunately, horses are expensive, but there's not that much money in horses, unfortunately.
Compared to other things, yes.
Like people, dogs, cats, even cattle.
Yeah.
And so we kind of get the short end of the stick. If we're the only ones using it, a lot
Right.
of times we lose it.
Yeah.
So,
What was the original label for on that?
it's an anti-protozoal.
Oh, interesting.
And so they were using it because they thought, oh, maybe this diarrhea is coming from a protozoal issue in the colon. And that's why they started using it.
Huh.
And it was
Interesting.
successful. And they found out it's not a protozoal problem.
But the anti-inflammatory. It's kind of like when you throw Oxytet at some things too, that you're like,
Right.
well, what did this do? So
We found out later it has great
Yeah,
MMP activity.
exactly, right.
Or the one I use is levamisole. It's a dewormer, but it turns out it's got an immunostimulant property.
yes, so
And one of the things that I do want to say on this topic is oftentimes people are like, well, their immune system's just not working. We need to do something for the immune system. Like, no, these horses do not need an immunostimulant. The problem is their immune system is working overtime.
horses are. There's something about horses that their immune system is just like so hyperactive. It's
Very.
either like 0 or like 150%.
Right.
And there's no in between. And that's why we see things like proud flesh in horses, because they just turn their, immune system on, and it's just like going into overdrive.
I like to say very few times in life do we need immunostimulation in horses. There are some.
They're very good at it themselves. They're too good at it.
That's usually their problem. Is
Yes.
They will overreact. The problem is they overreact in ways that aren't good.
Yes.
So, but yeah, that's a lot of where treatment focuses on that immunosuppression of these guys, and unfortunately, this is a tough one.
This is a tough one, but it's something very real that we see. I think it's something that's out there and a lot more prevalent than maybe what the literature says.
Like I said, I think it sees us way more than we see it.
And I think it's very much a spectrum too. I think there's
Yes.
a lot of horses that are just living with this, and they're pretty unbothered by it, and it's not necessarily causing major detriment to their life. But There's other horses that's not the case. And I think this is something that if we can kind of, spread some awareness about this, we can all kind of learn from it. And, I'm hoping again with, by the time that my career ends, that maybe we actually have some better management of this.
Better management. I'll take better diagnostics because it really hasn't changed since
Yeah.
I started. So, well, kind of sum this up, 3 things, or it doesn't have to be 3, but what are your key takeaways on this?
I'd say, again, this is something it's out there, and, we may not ever get a slam dunk diagnosis of this on your horse, just kind of based on what we can do. But, if you're seeing these issues with, diarrhea or kind of ill thrift in your horse, and we've ruled out a lot of other things and it's not there, then I hope you really like your veterinarian, because you're going to be having a very close relationship with them for the next little while, just trying to kind of get this under control. So, know that you're in this for the long run, but, we're here for you, and, we're all learning too. So it's, as you can kind of see from this, there's a lot we've learned, but there's a lot we don't know. Right. And, we're going to be kind of figuring this out together, and this is probably going to be a long, very frustrating road, but we have some tools in our pocket that we can do, and sometimes we can manage this.
Mm-hmm. I like to say that the best thing we can do is get that diagnosis.
Yes.
One of the keys on this diagnosis is a great history.
Yes.
Not the time to play stump the veterinarian and just see if we can figure things out. Give us the history. Even if you think it's dumb or maybe not important, just throw it out there. We'll sort out what's important and what's not. Because oftentimes it's that one dude, every December he gets diarrhea till about March.
And you're like,
And you're like, oh, wait a minute, hold on, what? Mm-hmm. And this is when you've been trying to figure out this weight loss all summer. And they finally throw that little fact out there. And you're like, hold up a minute.
Yes.
We got to go down a different route. Mm-hmm. So have that good history. Make sure what great idea is if you're dealing with one of these, a chronic diarrhea, chronic weight loss case, before the veterinarian gets there, sit down for, maybe the days leading up to the appointment, and just really start going back to your memory and trying to remember everything that's happened with this horse. Mm-hmm. And so that we can have that information, write it down so you don't forget, and really help us out. So
again, I love a journal. I love a notebook.
Yes.
I do enjoy when people come to an appointment with a little piece of paper or their notebook and things, and
very helpful.
I think sometimes I'm like, oh Lord, here we go. But
yeah.
There can be a lot of information in that, and again, sometimes all it takes is one little tidbit that maybe we didn't think was super important, but that's what connects all the dots.
Yes. So, well, I appreciate everybody listening today. Dr. Brown, thanks for being here. April, thanks for recording this podcast. Casey, thank you for editing everything. We really appreciate it. But most importantly, thanks to our listeners out there. We really enjoyed this. We're going to keep cranking through these episodes. We're going to keep doing this more and more because, like I said, we learn as much as y'all do. It really it's really a lot of fun for us. I really enjoy it. So even if we didn't have listeners, I'd probably still do this because I kind of like it. So, well, thanks everybody for being here, and we'll see y'all next week.
Bye.
Thanks. Bye.